I have a question to Richard.
Yes.
Okay. I enjoyed your presentation. It's very interesting. Did you decide on the insertion position of the link implant by painting company based on based on the result of this study?
Um, no, we did not.
No.
No, because the Paintech study was in 2020. We got into this point in the last 2 years.
Mm.
But the good thing was that in the Paintech study, what we tried to do, and I think Dr. Donner also shared some FEA studies on that, on from SIBO as well as from is from element from exponent as well in a comparison to the paintech approach per se. What we found was this: we tried in the paintech study to, yeah, because at that point no one had any consensus towards where do you place the implant. So what we aimed to do was to see in the hands of different surgeons, if given the same technique, and where would they place it, because the interossous region is a pretty large region to place your implant in, and different surgeons, different trajectories, and so on and so forth. So amongst the surgeons, based on their own anecdotal experience, they placed the implants where they felt it would perform the best. And then we compared that to see amongst each surgeon and where they placed the implant, where did they place it that gave them the optimal result. And I could just show, if I could share my screen, just quickly. Share. From our recommendations in nutation, counter nutation, we did recommend placement in the posterior region, especially for the male as well, and in addition to placement along the sagittal plane. So the painter implant places along the sagittal plane already, which should resist flexion extension, which is what we saw. But we saw that the best performance we got was when it was placed in the posterior inferior region as well. So maybe in the other locations, we could get somewhere around 20% reduction if we went a little bit higher. But when we came down here following sort of this trajectory, the same trajectory that Paintec had, we got somewhere close to like 70% better, 70% reduction of motion as well. So it's just, and this is from actual biomechanical studies, not finite element models, so which, as Dr. Donner said, the finite element models are things that we could always try to figure out what is best and what should be the consensus. But in an actual cadaveric study, we did see a range of about 20% to 70% reduction in motion in an intact joint. But it was then after that that we began to really explore how best do you fix the joint across all planes. And yeah.
Mhm. Thank you. So, Richard, so direct question, which of the fixation method in three that were shown today did you think were better for men and which were better for women based on your research results? Uh, would you unmute it?
I'll go to the last slide I had, and I would say that in the best placement for men, it was an inferior placement, while for women, it was a sort of superior placement. But the best placement that we could recommend across all for very rigid fixation, whereby you want absolutely no motion, was very similar to that Dr. Dow published in Weisendow, whereby it took two implants, one superior and one inferior. It's a bit different from the trajectories that have been shown here already. I could just show that very quickly just to show what the difference is. So contrary to placement at an angle, Dr. Dow's placement was not at an angle. It was really straight down on the AP. And that is also what we recommend, a straight down AP, no angulation into the joint. And Dr. Dow's results actually showed that when you did that, you could actually lift up the patient by pulling on the screw. And that is also what we arrived at across our placements. But just back to your question, in the male, the lower portion is more optimal. In the female, you typically would want both of them because there is both the superior and the posterior are very tricky to go with. So we do recommend this for at least for the female or for the woman, a double implant placement, one superior and one inferior. And for the men, typically a just placement inferior should actually give you more benefits compared to just placement, a single implant placement on the female joint. But you also see this in clinical basis that the more of the loosening happens with the female as well. So I think that really supports our conclusion that women require more fixation points than the male patients, especially.
Yeah, thank you. Very interesting. It's new information for me. Thank you so much.
Thank you.
So I've got another question for you, Richard. So at the beginning of your talk, you told us that you had 12 specimens with stable ligaments and 12 specimens where you cut ligaments.
Correct.
Is this enough to cover all the different types of SI joint morphologies that we can have? I was taught that it's like a fingerprint. You have millions of different SI joints, and just to do all these calculations basing on
a few
10 or 20 specimens, is this enough?
It's not enough, but it's the biggest study to date. No biomechanical studies has done more specimens than what we've done so far. So I would say it's not enough to say everybody has that, but it is much more than any other study has ever put out to date. So I'd also say we actually have more data. So we actually have about 36 going to 36 specimens right now. And we are still processing, and we would eventually publish even more on that with a very large sample size. But yes, you're correct.
We have seen this in knee problems. So when you look at knees, the kinematic of knees is completely different from one part of the population to the other one. It's just 100 degrees different. And so having this maybe in a complicated joint like the SI joint is, then maybe we need to understand a little bit more of different mechanics, different morphologies have to choose the right implant. Like in knee prosthesis, it's the same there. Any other questions?
I think there's been a lot of talk about cluneal nerve irritation and SI joint pain, and I was interested in Dr. Warner, if you could comment on your denervation technique and the cluneal nerves or the dorsal rami of 1 and 2, or kind of where are you specifically hitting one or the other? And before you did this, did you notice a big difference post-operatively when you added this on to your fusion technique?
Thanks for this question. I think especially the one about the cluneal nerves is very important. If you have skinny patients and you have a problem on the iliac part of the SI joint, then we really try to stay medially and underneath the ilium in order not to hurt any cluneal nerves. You can actually easily identify them once you pull out the scope and you stay above the fascia scarpa. I don't know the English term for it, scarpal fascia, which is a subcuticular fascia. The cluneal nerves always run superficial to it. So we try to stay deep underneath the ilium in these cases where you have clinical symptoms there. And in terms of denervation, we go down to S4 but we test it the day or two preoperatively. We mark it, and we denervate wherever the pain of the patient is. And we've experienced a substantial benefit of the denervation, which is why I actually routinely do it in all the patients, except they come back at 6 weeks and tell me they have no pain, which of course can be the case, but is not the, well, it's rather the exceptions to have a patient which is showing up with no pain.
Do we do denervations as standalone technique, endoscopic denervations, or don't you do it because you are afraid of destabilization, taking away ligaments, at least a part of them?
I do not, to be honest, because I'm just too afraid of you know doing the patient something worse, because especially if you have young women which are very unstable and have some hyperlaxity, the denervation alone is not going to help, because you know these nerves grow back, and after like 2 years they are back, the pain might be back. While if you have a stabilization before you denervate them, you never have that problem. And you, I can't, maybe 1 or 2 patients in over 700 that we have denervated, 1 or 2 might come back for an additional denervation, but usually it's somewhere deeper, or they want the facets to be denervated. Usually patients do not come back after that.
Daisuke, I've got another question to you.
Yes.
You were telling us that you had maybe the way of walking might be influencing the SI joint. Do you think that it can be, or we can use this correlation the other way around, so we can make a gait analysis on a treadmill and see how people walk and maybe see the problem? Do they have a SI joint problem? Might this be another diagnostic instrument?
So it is a difficult question. So now we are at the point that we can know the movement movement of SI joint while walking by Android model, because I cannot see the joint itself in our clinical practice. So I imagine that when the patient have a pain when initial contact to mid stance, the anterior part of the sacroiliac joint is damaged. And if the patient have a pain in the terminal stance, I imagine that the patient have a posterior side of the joint. It's a clinically relevant from Android model. So I have to we have to develop the practice by using the information from Android model.
Okay. Anybody else who has questions to these experts in biomechanics of the SI joint?
Yes. Martin, would you be able to check the chat function? Chat. So I wrote a question to Richard and all surgeons.
Yeah.
Would you...
In women, laxity of the pubic symphysis is associated, particularly in postpartum sacroiliac joint pain. This is also the topic of the next webinar. Yes, we will introduce the next webinar. In these in this case, I think so. So what is your question about this?
Yes. So as there is a way to fix the pubic symphysis while simplifying the fixation of the sacroiliac joint. This is what I thought of when I read Dr. Werner's paper. I'd like to know the instability state of the pubic symphysis and the change in the axis of motion of the sacroiliac joint itself. And the surgeons, do you have experience? Sacroiliac joint fusion, both sacroiliac joint fusion and pubic symphysis fusion at the same time, and the effect of that.
Okay, and maybe I would go first. And just to the question of the change in axis of motion, part of the studies we did as well, we resected the pubic symphysis. I think that everyone who's done SI studies, just as Dr. Cross as well, we do resect the pubic symphysis to induce a distability state. We do see a lot of motion in axial rotation when we do that. And I think that leads to a lot of posterior compression of the joint when the pubic symphysis is resected, and it may be a place to play for some form of distraction posteriorly in order to bring the pubic bones back together. But definitely we do have some data, and I think that would be great to actually present in the next webinar, that the axial rotation center moves backwards actually when the pubic symphysis is cut.
Martin, I have a question, or I have a comment. This is John Stark, and I have fused, let's say 1,000 SI joints. I've never fused or touched the pubic symphysis ever. And I've never seen a deficit. I've never seen local pain which occurs there. And I believe, and this is a religious belief rather than practical or biomechanical one, that when you fuse effectively one side of the one SI joint, you change the other 2 points of contact from universal joints to 2 points of a hinge. And so you change the other side, the demands on the three-dimensional movement of the pubic symphysis and the three-dimensional movement of the contralateral sacroiliac joint to 2 dimensions, and which I think is why we do not have a very high incidence of bilateral SI fusion. But I want to make that comment. I know some people fuse this pubic symphysis. We just have never done it, and it's never seemed necessary.
No, thank you.
Okay. Some more comments, questions? So I will share my screen. And we'll go over to present the content of the next webinar, which will be on June 16th, chaired by Vikas Patel from Colorado. And it's about pregnancy and pregnancy-related and birth-related pelvic pain and what to think and what to do. I hope that all of you had fun this afternoon or this morning or this late night and learned a lot from all these specialists. And so I think if there are not any other questions, I would close today's webinar and want to say thank you to the sponsors once more, Ottobock and Medacta. And thank to all the guys who had the talks. And thank you for your participation. Have a good night or a good day or whatever, and see you next time.
Thank you, Martin.
Thank you very much, Martin.
Outstanding, Martin. Thank you.
Thank you very much.
Welcome.
Good.
Thank
Good
you.
Thank you.